today I'll all right, so today I'll pick it just right from where we ended, where we ended our class. So we did premature. We got to understand that one of the issues that could happen during labor, it's when the membranes, sorry, when you have I mean, the amniotic membrane being ruptured before labor actually sets in. It poses a lot of risk to the mother and that of the baby or the fetus, if you want to put it that way. And so we also established the fact that management is largely dependent on the gestational age. So if the gestational age is something that is good around getting to term gestation, the healthcare provider might allow labor to continue or might allow labor to progress and then the fetus delivered because of the complications that are associated if the labor is kind of delayed, okay, because infection is a concern, which, yes, infection is largely the main issue. And so we determine what to do for the clients based on the gestational age. However, if the gestational age is not quite closer to 10, and then we know that if that happens and you deliver the baby, you are going to definitely get premature labor. And so premature baby, as we know, comes with some form of, complications. They are more at risk of infection. Their lungs are not matured enough for gaseous exchange, and so they become at risk of um respiratory difficulties and all that. Okay. So we need to know how to assess a client to know that it's actually the membranes that has ruptured and whatever is coming out is the amniotic fluid. So we spoke about how to perform nitrazine test using the nitrazine paper where you expect a blue color change. However, we said that there are other things that could give you a false positive result. And so examples of the false positive result is situations where you could get a false positive result is when the woman let's say had engaged in sexual activities prior to what we call the rupturing, okay, or prior to maybe the person experiencing the fluid. The pH of what we call the amniotic fluid and that of semen are the same. And so if the person had engaged in sexual activity prior to rupturing, and then you go perform your nitrazine test, you have to actually verify from the woman if the woman had engaged in sexual activities, prior to reporting, okay. Because if the semen are there, it could be that your test picked that of what we call the semen and not the amniotic fluid. So those are the things that when you are doing nitrazine test, you have to take into consideration and you ask your clients about that. And so we also said you have to look at consistency, you have to look at vital signs, temperature increasing indicator is what we call maternal infection. And then when fetal heart rate also increases, we also say that it's also largely indicates that there is what we call maternal infection. We looked at how to manage. We said we don't do, we have to avoid that's vaginal examination in order to limit what we call infection. You have to do a nitrazine test. You have to assess the gestational age to know, what gestational age the woman is within. That is what will tell you what to do. The action the healthcare provider is going to take will largely depend on gestational age. You give your antibiotics. Of course, we are saying that infection is the main problem. So you have to target that by giving your antibiotics, right? Yes. So that was, just a summary of what we did before we ended the class. if you have any question, if you have any input, if you have any additional what I just summarized, you can raise it. So understand that when it comes to premature rupture, the major concern is infection. Most questions I've seen on premature rupture is largely on infection, okay, and then how to prevent the infection and all that. Then let's talk about prolapse cord. Prolapse.
Prof, I think it was me. I wanted to ask one question, and you said I should ask it when we
Yeah,
meet today.
yeah, yeah, okay.
Yeah, my question was about meconium stained lico
Mm-hmm.
and prematurity. You
Mm-hmm.
mentioned that when you examine and you see that the premature fetus or the mother is having meconium stain and the gestation is prematurity, you have to
Mm-hmm.
prepare the mother for CS.
Mm-hmm.
Yeah, so and I'm a midwife, and I know
Mm-hmm.
that prematurity cases we have delivered them with meconium stained
Mm-hmm.
without CS. So I wanted to find out whether with NCLEX you have to
Oh,
when you see
okay.
meconium stained like with prematurity, you have to prepare the person for CS.
Okay. Okay. So that's why I always said, okay, we have midwives. It's all right. So when it comes to delivery, okay, it's not only one thing that will determine whether you have to send you have to perform CS for the mother, or you have to do CS to take off the baby, okay? Just like, you have to assess the fetus to know the state of the fetus. If the fetus can tolerate, SVD at a time of when there is meconium stain, of course, if the fetus can tolerate what you call, SVD, you can proceed with SVD. But you have to look at the state of the fetus. Is everything okay? So based on assessment, is the fetal heart rate normal? Is there any complication aside the meconium stain? Okay. So you don't just look at only the meconium stain aspect and then say that, okay, let's then send the woman in for cesarean section. You have to consider other factors. If at the time of the meconium stain, the fetus is doing well and the fetus can tolerate normal spontaneous vaginal delivery, of course, we go ahead to do your SVD to take the baby off. So it all depends on assessment and then the state of the fetus. If the fetus is fine, and then the fetus can tolerate normal spontaneous vaginal delivery based on fetal heart rates, and then yes, likely based on fetal heart rate. If there's no any distress and all that, of course you can go ahead with your SVD. But if you notice that there's all the various abnormal fetal heart rates we spoke about, if maybe there is any form of fetal distress noted based on the fetal heart rates, you wouldn't want to put the fetus, into more stress. And so with that one, you quickly have to arrange for cesarean section to be done to take the baby off.
Okay, thank you so much.
Yeah. So we don't just even even I think when we started with um labor and I was talking about was it breach, I did mention that even though some might want to deliver the baby, okay, through SV, but you don't want to complicate the situation. So in that, we quickly arrange for CS to be done. We don't want, so you have to look at, other things to determine whether the fetus is fine, okay? So it is not a one-way thing. So you have to consider other assessment apart from the meconium so that you can determine the state of the fetus. All right, so I have a midwife here who will help me a lot in what we have to do. All right, thank you. All right, so let's talk about prolapse and what we expect to know. So I think last week or last week we spoke about um cord prolapse, or we spoke about variable decel, right? We spoke about variable deceleration. And we said a variable, I specifically said a variable decel is to me one of the worst kind of, fetal heart rates readings that you might encounter. Okay. And we said the cost of it is when you have the the umbilical cord being pressed on, okay, or when you have movement through the umbilical cord being impeded. And we said that what could lead to that is when during labor you have the cord coming out first, and then the presenting part exerting pressure on the cord. What we noted was that I even showed you a picture where you notice that there's something blocking what we call, or something pressing on the cord. Okay. And so that is what leads to what we call variable decel. Okay. And so one of the things that could cause variable decel is when you have prolapse cord. Okay, when you have the umbilical cord displaced between the presenting parts and then the amnion, or protruding through the cervix. Okay, so the umbilical cord or the cord is coming out first. Okay, and then the presenting part is exerting pressure on it, causing compression of the cord and then compromising fetal circulation. Okay, so assessment, you are likely going to feel when you do your assessment, you see that there is something coming out from the vagina and it is not actually the presenting part. Okay. So the client has a feeling that something is coming through the vagina. Then the umbilical cord is also visible or palpable. So you can visibly see the cord out. So someone asked me that, what do you do if you can't see the presenting part and then the cord is out? And I told the person that is why positioning is there. So now coming to look at how to manage such cases. So position is something that you can position the woman and it will kind of shift the presenting part back, okay, or kind of push the baby kind of back, okay. Apart from using your hand to lift what we call the presenting part of the cord. That is one thing you can do. So in prolapse cord, you could see the cord coming out visibly, or you can palpate the cord. There is what we call fetal heart rate, which becomes irregular and slow. And we learned about this when we're doing variable decel, right? And so we said that in variable decel, fetal heart rate drops, and it could drop as low as 70 beats per minute. Okay. And then it could stay there for almost about um 60 seconds, almost 1 minute, even before it returns back to the baseline. So fetal heart rate becomes irregular and then slow. The fetal heart, the fetal heart monitor will show a variable decel. That is what I just said, or bradycardia after rupture of the membranes. If fetal hypoxia is severe, then rapid fetal activity may occur and then ceased. So whenever I'm doing this, I always use that example that when an adult is about to die, if you have managed, signs of an impending death. It's even in the NCLEX, you need to know signs of impending death, right? And so you notice that heart rates will rise up and then respiratory rates will go up. And then at a point, everything will cease. Why? Because the fetus is struggling. So the fetus is struggling to catch up with what we call enough oxygen because the delivery system has been impeded. And so the fetus has to kind of, fetal activity will kind of increase, just like if someone is grunting for air, right? You see the person will be struggling and then the increase in activity. And so when there is severe hypoxia, severe fetal hypoxia, what you notice is that fetal activity at that moment will kind of increase. because the fetus will have to kind of struggle to get what we call oxygen. And then as fetal activity increases, demand also will slow. The little energy that is there will also be used up. And so at the end of the day, you realize that fetal activity will cease. And that means that you're likely going to lose your baby. Okay. So prolapse cord is one of the things that it's very, it's very severe. And so it's one of them, emergency, obstetric emergency. If you are monitoring a pregnant client and the person is in labor, the person is going to is experiencing prolapse cord. You want to monitor. And so another thing that could also lead to prolapse cord is when you have a ruptured membrane. Okay. Because when the membrane ruptures, remember it is fluid that is coming out because the membrane houses the amniotic fluid. Okay. And so when the fluid is coming out, the fluid can sweep the cord alongside. Okay. And so people with um premature rupture, or when someone is in labor and the person experiences ruptured membrane, one of the things you have to monitor for is prolapse cord, because the fluid that is coming out can sweep the cord alongside, and that could lead to what we call prolapse cord. And so when it comes to management of prolapse cord, when we're talking about variable decel, I said one of the things you can do to kind of stop the whatever is ongoing is one, positioning, and then or one by lifting the presenting part, okay, and then positioning. So you have to intervene immediately to relieve what we call pressure on the cord, okay, so that the fetus can receive adequate oxygenation. Okay, so the main goal is to establish fetal oxygenation, or is to relieve pressure on the cord so that it can re-establish circulation to the fetus. The nurse should never attempt to push the cord into the uterus. So this is one thing that the NCLEX will ask you, this very thing. If someone is experiencing prolapse cord, which of the following uh, actions by the nurse will require immediate intervention? And then you have wear sterile glove to lift the presenting part of the cord. Then you have to wear sterile glove and push the cord back. Okay, push the cord back into the uterus. Then you have probably positioning. Okay, assist the woman into maybe a left lateral or into a trilembic position. Or you have another option. That's the third point. Then the fourth option is that inform the healthcare provider. And so what you need to understand is that in prolapse cord, we don't push the cord back. It is rather the presenting part that needs to be elevated, okay, to relieve the pressure on the cord. So never attempt to push the cord into the uterus. Then the situation is also emergency. So I said that it's one of the obstetric emergencies. So when it comes to prioritization, please, when it comes to the last time I made mention of someone who is having what we call um ectopic pregnancy. And I stress on ectopic pregnancy that when someone is experiencing ectopic pregnancy and there are signs of rupture, that client becomes high priority, or they are obstetric emergencies. So when it comes to prioritization, I always stress on it, okay, who to see first. And so if you have a client who is experiencing prolapse cord, there are signs of prolapse cord and you need to prioritize. Check out what you call prolapse cord first. Then you check out the other clients. Well, you might have to consider the other clients, okay? But when it comes to prioritization, this is one of the conditions or one of the situations where when it comes to who to see first, you're likely going to attend to that person first. Okay? So understand that it will require emergency attention. Delivery must occur. So usually by cesarean section, the baby will be taken off. You have to elevate the presenting part that is lying on the cord by applying finger pressure with with a sterile gloved hand to relieve pressure on the cord. So that is what I was saying, that when someone is experiencing prolapse cord, what you have to do is to do what? Is to wear a sterile glove. Remember sterile glove, then you lift the presenting part of the cord. Okay. Then you place the client into a Trodelenbeck position or modify left lateral or a knee chest position. How we know knee chest? So knee chest will also kind of push the baby or the presenting part inside. Okay. But the Trodelenbeck, we all know Trodelenbeck, you have to lift the lower extremities and then the baby or the presenting part will kind of push back. Okay. Then another thing you have to also do is by covering the cord with what you call gauze that is saturated in normal saline. Okay, sterile gauze saturated in normal saline. Why do you do that? We want to prevent the cord from drying up because the cord is exposed to what we call air or is exposed to the environment. And so we don't want infection to set in where you have cracks happening on what we call the cord, and then it becomes a medium for what we call bacteria to invade. Okay, so we wrap the umbilical cord loosely in a sterile towel saturated with warm, sterile, normal saline. This is to prevent the cord from drying up and prevent infection. Then you have to monitor fetal heart rate and assess the fetus for hypoxia. So in hypoxia, fetal heart rate is going to drop significantly. Fetal activity is going to go up, just like I made mention of. So you have to monitor for fetal hypoxia. You prepare to start your intravenous infusion or increase the rate of administration of, the existing IV fluid. So mostly normal saline or Ringer's lactate is what we use in it. Then you stay with the client, you call for assistance, and then ask another person to notify the healthcare provider. Oxygenation is very important. Okay. And so administer oxygen and then you wrap. I think I've talked about that. You document and then whatever you did, you have to also document that. So that is on cord prolapse, what you do for clients who is experiencing cord prolapse. Interventions, assessments you're likely going to see, and then what happens in cord prolapse. If you have any question, if you want to add up anything, you can bring it up before we continue. Okay, so let's progress if there is no question for now. So let's talk about supine hypotension. The last time I was doing question on the platform, I kept a question there. The question was, I think, something you will intervene. Okay, that kind of question. What will you intervene if you see, let's say, an LPN or let's say a fellow RN doing, and it had to do with positioning. Okay, let me state that when it comes to maternity, if the woman is pregnant, never go in for position like um supine. That is position the woman flat on the bed, on the back. It is a no-go area when it comes to a pregnant woman, a woman who is in labor. Okay. The best position is the sideline or left lateral or lateral position. Okay. Why so? We do that to prevent what you call supine hypotension. I spoke about this when we began what we call maternity, that in supine hypotension, when you position the woman in the supine position, the pressure of the uterus is exerted on what we call the inferior vena cava. Okay, or so it's exerted on the vena cava and then that of the aorta, and it reduces what we call cardiac output. So when you have cardiac output reduced, there's going to be signs of hypotension because the amount of blood that is returning to the heart is going to be, reduced. For it to be kind of circulated back to the heart is going to be reduced. So the individual is going to experience hypotension and then signs of hypotension, dizziness, and then the person is going to have syncope and all that. So supine hypotension, it looks very simple, but you might get a question and they are asking about supine hypotension and you wouldn't know that it is supine hypotension. They mostly ask in relation to positioning. Okay, so note that when someone is pregnant, supine is a no-go area. They might not really mention supine, but they will describe the position that you have to know that this is supine position. So they will say that lie the woman flat on the back. Okay. Or you say that the nurse assisted the patient to lie flat on the bed. That should quickly tell you that this is supine hypotension. And if the woman is pregnant or the woman is in labor, you are not supposed to put the person on supine unless probably you are doing your assessment. Then when you finish, you assist the person back into what they call the most appropriate position, which is a lateral position, right? So let's go into it. So supine hypotension, which is also known as vena cava syndrome, occurs when venous return to the heart is impeded by the weight of the uterus on the vena cava, right? So this will result in partial occlusion of the vena cava and then the aorta. And so there will be cardiac output or reduced cardiac returns, cardiac output, and then there will be reduced blood pressure. So this is what happens in people when you position that person in the supine. There's going to be pallor. The person is going to experience dizziness, difficulty in breathing, and all that. There's going to be tachycardia. And so those of you who have our women here, our sisters and mothers here, if you got pregnant before, then you make a mistake and you sleep on your back, you see how it feels. You feel tired. Sometimes you find difficulty, even breathing in. Okay. So there's going to be tachycardia. Hypotension is there. So the two, we know that they happen together as a compensatory mechanism. If blood pressure drops, heart rate has to go up to compensate for the um the hypotension. Okay, so it's the tachycardia is a compensatory mechanism of the hypotension that is happening in the system. There's going to be sweating, cold, clammy skin, and then there's going to be fetal distress because the fetus also depends on the mother at long last. So if the mother is experiencing reduced cardiac output, supply to the fetus is also going to be affected. And then there is what we call fetal distress. Our interventions are actions to shift the weight of the uterus off the vena cava. And so we position. So position the client on the side. So as I said, lateral position is the most preferred position to assist the woman into. So position the client on the side to shift the weight. You have to also monitor vitals, fetal, assessment, fetal heart rate. And then to prevent supine hypotension, avoid supine. As I said, in the questions, they are not going to mention supine hypotension straightforward. Of course, if they mention supine hypotension, everybody will know. And so they would want to trick you by probably describing the position. And so you have to know that this kind of position is no-go area when it comes to positioning of a pregnant client. And then you position the client by placing a pillow or a wedge under the client's hip to also displace the uterus of the vena cava. That is another thing you can also do for the woman. That is on supine. It looks very simple, just like I said. But when you are reading your question, pay attention. I noticed that a lot of us, when we read question, we don't pay attention to details. So pay attention to details when it comes to the question reading, and then spot what is not needed, and then spot what is needed, especially when it comes to the options. Okay. I probably will get a question on that. It will be very easy for today. because we just did it, and so the information is fresh. But after here, we have to be able to recall all these things so that we can produce them when they need be. Any question, any inputs before I talk about preterm labor quickly? So let's talk about preterm, and what you do in preterm labor. In preterm labor. So in preterm labor, we said that labor when labor happens after 20 weeks and then before 37 weeks of gestation. This is the US standard. I don't know Ghana here what we use. Last time someone told me that Ghana we use 24 weeks, right? That is what someone told me, but we are using US, so we are talking about US, okay? So in US, any labor that happens after 20 weeks and then before 37 weeks is termed as preterm labor. We know before 20, if it happens before 20 weeks, that is either abortion or miscarriage. And then if it's after from 37 weeks going, it is a term gestation. Okay, so that is term labor, right? But if you have labor happening between 20 to 37, that is the duration we all need to know is what you call preterm. And so in preterm, you need to know the weeks, you need to know some of the risk factors that could bring about what we call preterm labor. And then, I mean, what could tell you that a woman is going into preterm? That is why we did signs of true labor signs and false labor signs. So if a client is around 33 weeks of gestation or 30 weeks gestation, and a person is experiencing signs of true labor, you need to know that this person is at risk of having what we call preterm labor because all that a person is describing to you are signs of true labor. Pain, location, contractions being regular, okay, and then cervix dilating alongside what we call the contractions or cervical dilation being progressive. These are things that we learned the other time. Okay. So preterm labor, as I said, labor occurring between 20 to 37. Then the risk factors, there are a lot of factors. Age is a concern, the age of the mother. And so the age we look at younger age and older. And so if the person is less than 18 years, or the woman is less than 18 years, and the mother is also about 40 years, about 40 years, they become at risk of what you call preterm labor. So the optimal age for delivery or the optimal age for a woman to have a baby should be between 18 to 40. So if the person is less than 18, person becomes at high risk of experiencing preterm labor. And then if the person is also about 40 years, the person also becomes at more risk of what you call experiencing preterm labor. So age is a factor, so you have to consider the age. Then some medical conditions, okay. If the person also has um some form of problem, obstetric problems, okay. And so present and past obstetric problems. You have to ask the person, has that person ever had a preterm labor before? Is there any impending complication or any problem with it with that pregnancy that could predispose the person into having a preterm labor? Then infection is also a concern. Okay, so maternal infection is also a factor that you need to consider. That is why we talk about touch, that if someone is pregnant, the person has to do everything possible to prevent those infections we spoke about when we did touch. Social and then environmental factors. Okay, people who smokes. Okay, substance abuse. Those who smoke, those who use drugs, just as we know, are all risk factors. So the social factor, you can also talk about support system. If the person doesn't have very good support system, person thinks a lot, there's emotional issues and all that, it could all cause what we call preterm, or it could affect the mother, and along the line, the mother could go into preterm. So other factors you need to consider is when there is what we call multi-fetal gestation or multi-fetal pregnancy, right? And so if the person is carrying more than one pregnancy, let's say twin gestation, or maybe triplets. Okay, so multi-fetal pregnancy or gestation. Then anemia and all those things would also decrease oxygen supply to the fetus, and that could lead to premature labor. And so these are some of the things that we need to consider when it comes to premature labor or preterm labor, sorry, when it comes to preterm labor. Assessment, what are some of the things that I will tell you in a question? And so you are reading your question. The woman is at 33 weeks gestation, and the woman tells you that she's experiencing painful contractions and they are regular in nature. Or the woman calls you from the house that she's having contractions that are regular, which is painful in nature. And then the pain
Oh,
is
you've
located
been
at the
already.
back.
Right?
Kindly mute up.
Where to where you see?
Kindly mute up. Madam Mary, you're muted. All right, let me mute it. So the patient calls you and tells you that I'm having contractions, which are painful in nature, and the pain is more located to the back. Okay, to the back. Then they tell you that the person tells you that she's having pelvic pressure, and then there's changing character and amount of what we call discharge. So we said that when someone is going into labor, there's going to be bloody show, or there's going to be show, even though we said that show isn't actually sign of true labor, even though it could happen even before labor setting. But when the person is having the contraction and all those things I spoke about, and then there is what we call discharge that is coming out, indicating there is what we call bloody show, then or could tell you that there is what we call ruptured membrane. Okay, so when there's ruptured membrane, you notice that the fluid will come out, the fluid will be a little bit more thicker or thinner. There's bloody, colorless and all that. So you have to look at that, whether there is ruptured membrane. Definitely, if membrane is ruptured, that's why I said that it puts a person at risk of preterm labor. So preterm labor, you have to assess for ruptured membrane. Then um you have to assess whether the fetus is coming out. Okay, so you assess for presence of fetal fibronectics in the cervical canal, shortening of the cervix as well. So the cervical length. So you have to assess signs of true labor. You have to do your cervical assessment. You have to look at whether there is dilatation. Is dilation going on? Is the dilation regular in nature? Is it progressive enough? Okay. So all these things, you look at the gestational age at which it is happening. And the moment you notice that these things are happening, first we consider the gestational age. And so all these actions that we taking will depend on the gestational age. Is the gestational age good enough? Can the fetus, tolerate normal, what you call atmospheric environment when the fetus is delivered? Okay, are the lungs matured enough? Okay, so all these things are things the healthcare provider will consider before, if he will delay the pregnancy or he will delay the labor, or he will allow the labor to continue. Okay, so first, the focus is on stopping what we call the labor. And so first we consider stopping the labor if that is indicated based on the assessment when the gestational age, right? And so if the gestational age is not quite closer to 10, the healthcare provider will want to do everything possible to halt the labor from progressing. Then we'll give our medications that will help the lungs to mature. We'll talk about them and all that. So you identify and treat infection. So we says infection is a concern when the membranes ruptures. Definitely in preterm labor, the membrane will rupture. So if the membrane get ruptured, infection is much of a problem. So you identify infection, you treat, you restrict activity, because the more the mother engages in activity during this stage, then contractions will continue to occur, and then cervix will continue to dilate. So we want to restrict activity. We hydrate the woman, we maintain bed rest, and then appropriate position left lateral. We do fetal assessment to note fetal status. We then administer IV fluids. Okay. Then we give our tocolytics. So if you know tocolytics are used in halting labor, right? So we give tocolytics to halt labor. Example of tocolytics are max sulfate, as we all know, right? And then they use what we call nifedipine, which is also um antihypertensive, can also be used as a tocolytic to halt what we call pregnancy. But I think largely max sulfate is one of the medication that then we can also give our steroids to help with the lung maturity, right? So we give the steroids. Remember, the steroids are not given to the baby. The steroids are given to the mother. And so example of the steroids you can see in the NCLEX is the dexamethasone. And so the woman is in preterm labor, and we are giving the dexamethasone, and they are asking you what is the purpose of the dexa being given, right? So the dexa is to enhance lung maturity. Okay. And so you could when there is preterm labor, we give what you call our steroids, okay, as well. So I made mention of tocolytics, which then the nifedipine I made mention of. Then they also use indomethacin, which is also a tocolytic. Even it's NSAIDs, okay, it's NSAIDs. That is the class of medication it belongs to, indomethacin, but it's also used in what we call managing preterm labor. That is, it serves as tocolytics to halt labor. What it does is that it reduces contraction by blocking what we call prostaglandins, and which triggers the contractions and all that. Okay, same thing there. Nifedipine also slows down the rate of complication. It prevents calcium channels from entering the uterus, which could cause, because it's a calcium channel blocker. It's when you give the nifedipine goes in there to block the calcium channels. And so that you need the calcium for contractions, right? For uterine contractions. And so if the calcium are blocked by the action of the nifedipine, you don't have enough calcium to cause what you call the uterus to contract. Okay. And that is it. So I think another one too is tebutalin. That is also quite used. Well, you might see tebutalin more often in the NCLEX. So it's also a short-acting medication that also helps the uterus to relax. So that rather, and so you see that all of them have their action. We said that nifedipine blocks what you call the calcium channel. Okay, it blocks the calcium channel, so the uterus doesn't receive calcium that will stimulate it to contract, right? We said indomethacin blocks prostaglandins, and so prostaglandins also help with uterine contractions. Then tebutalin will suppress or to relax the uterus, right? So these are all examples of um what we call the tocolytics. We'll talk about the medication probably tomorrow. Some of the few medication we need to know when it comes to maternity. Then we can also give our 17 alpha hydroxyprogesterone caprate, right? Which is known as 17p injection, which also decrease the risk of preterm delivery. And so when it comes to preterm, I said that look at the gestational age, right? So they will describe signs of true labor in the question on your assessment. And then the gestational age is around 33 weeks, 34 weeks, and the person is experiencing those. The moment you notice that, the first thing that should come into your mind is that this is definitely preterm labor I am reading on. Then the actions will continue. Probably you have to report to the healthcare provider, and then the other interventions we spoke on will continue. Any other thing I've left out on preterm labor you want to bring it up? Any input on preterm? Any addition on preterm? Before we talk on precipitous labor and delivery. Last time I posted a question on precipitous labor, and almost everyone who answered the question had it wrong. And I was looking at it. And so in precipitous labor, just understand that labor that is lasting less than 3 hours. Labor lasting less than 3 hours. And so from the time the person started experiencing signs of labor up to the time the person delivered, if it is less than 3 hours, understand that the person is experienced or the person has experienced what you call precipitous labor. And someone who experiences precipitous labor should be identified as someone who is at high risk of bleeding or high risk of experiencing PPH, postpartum hemorrhage. Okay. And so there are people that you want to also prioritize them first when it comes to who to monitor or who to see first. Okay. So understand that precipitous labor is what? Labor lasting less than 3 hours. And so if from the time of the person starting to experience the signs of labor up to the time the person goes into labor, if it is less than 3 hours, it is termed as precipitous labor. And then it is obstetric emergency. We don't halt this type of labor. And so when you notice that someone is in labor and the moment the person presented, or the moment the person came in less than 3 hours, the person is going into labor. Note that these people or this person, you have to allow the labor to continue. You have to prepare for such cases. So you have to have your emergency tray available for what we call precipitous delivery. So that the moment you notice that a person is going into labor, you continue to deliver, then you continue to monitor for signs of what you call hemorrhaging. So ensure that, so precipitous labor is labor lasting less than 3 hours. Interventions for that. So for these assessments, you know that from the time of the person presenting, let's say the woman is at 38 weeks, let's say 39 weeks of gestation, walked in or was rushed into the emergency ward and then to the labor ward. And then it says that in 2.5 hours time, the person goes into labor. What are the things that you have to do? Understand that this is precipitous labor, or that is sign of precipitous labor. So the person is going to present with all the signs of true labor, right? Contractions will be there to be regular. Then everything that will help you to know this is signs of true labor will be present. So you prepare to deliver the baby. We don't halt this kind of pregnancy, just like or this form of labor. Allow it to continue. Ensure that a perpetual delivery tray is available. You have your hemostat on it to help stop what we call bleeders. You have your scissors to cut, and then you have your cord clamps and all that. it should be on your what we call your precipitous delivery tray. This is a tray that has to be available so that in case you have a client who is experiencing this kind of problem, you just go pick your tray and then you attend to the client, right? Then you stay with the client at all time. You provide emotional support. You keep the client calm. You encourage the client to pant in between contractions. You prepare for rupturing membrane. When the head start to come out, and then if the membrane hadn't also been ruptured. Note that do not try to prevent the fetus from being delivered. Go ahead to do your delivery. But what you have to take note of is that these people are at high risks of what they call bleeding, or they are at high risks of experiencing postpartum hemorrhage. So pay much attention to them, prioritize them if you need to prioritize them among other clients. Okay. So let's say you have 4 clients. One just delivered about 8 hours ago, and then says that she's experiencing chills. You have another client who delivered, let's say, 12 hours ago and wants assistance with how to breastfeed the baby. And then probably you have a patient who reported to the labor ward in 2 hours ago and then had delivered. Then you have that is the only thing they will say. Someone reported to the labor ward in 2 hours time and delivered. Then you have another client, maybe so you might think like someone is giving complaints of fever, or someone giving complaints of chills. Someone is asking for assistance on how to breastfeed. That is not much of a problem. Then someone had delivered within 2 hours upon arrival at the labor ward. There's no much other thing. But what you need to know is that someone who reported to the labor ward in just 2 hours and then delivered is a concern, because the person experienced what we call precipitous labor, and that person is at risk of experiencing PPH. So that patient would need to be attended to first, even before you attend to the woman who probably is complaining of chills and that and other things. Okay. So that is how they will frame it. You need to know that this is what we call a precipitous labor, since the labor lasted less than 3 hours. And they are what we call obstetric emergencies. They are more risk of what they call um hemorrhage or postpartum hemorrhage. So you have to assess them first and then attend to them first. Any question on precipitous labor before I speak on probably our last one? So someone says that, so a woman who comes to the labor ward and 8 cm dilated and delivers after 2 hours. So if the person we are not looking at the time the person reporting. That is not the main thing. But we are looking at from the beginning of signs of labor. Okay. Someone could stay home and the labor started like let's say 12 hours ago, and now they are reporting. And so last time when I was doing this, someone shared an experience that she has ever experienced. So what she said was that she went for antenatal, and then the time she was leaving the house, she wasn't experiencing any sign of labor. She went for her normal visit. I think she was at term around 38 weeks and all that. And then when she went over there, she started experiencing contractions and all that. So they quickly rushed her into what you call the labor ward. And so from the time she started experiencing the labor up to the time she delivered was less than 3 hours. That is what I'm trying to say. So if the person presents to the labor ward, okay, and then from the time the labor started up to the time of delivery, if it is less than 3 hours, that is precipitous labor. So if, of course, the person presented at 8 cm dilated, and that is just the beginning of labor, okay, And then in less than 2 hours, the person delivered. That is precipitous labor. I hope you are getting the picture I painted. Right. So someone could experience signs of labor like 12 hours before they brings the person in. That is not precipitous because labor started way before the person was brought in. But we are looking at from the beginning of labor up to the end. If it is less than 3 hours, it is precipitous. Any question? Any
Hello,
addition?
sir.
Yes.
Oh, sir, please, it's just an experience that I want to share.
Mm,
My second child, I experienced the same thing, and I had PPH after the delivery, severe one.
mm-hmm, mm-hmm.
Uh-huh. So it's
Okay.
really real. It's real. That within a 3 hours interval, the bleeding afterwards is very severe. It's not something that comes like let me say the flow is just gradual. It comes very heavy.
Okay.
Uh,
All
heavy.
right. Okay, so
Yes.
that is why when you are prioritizing, you need to prioritize them first. Okay, so thank you. So that's she also gave us her experience that she has ever experienced precipitous labor before, and she had PPH after the delivery. So it puts them at more risk. So don't just say that oh the person reported and so in 2 hours time the person has delivered, or in just 3 hours time the person has delivered, so it is good. No, monitor that patient. Pay much attention to that patient. Okay. So when it comes to prioritization, this is another key I have given you. When it comes to prioritizing what we call um people, or let's say women in labor and all that, you know that presbyterian labor is a concern. Any other inputs, any other question before we talk about shoulder dystocia? Then ruptured membrane. We have a few things to talk about, then start our questions. Then we talk about shoulder dystocia. Shoulder dystocia. So in shoulder dystocia, it is very simple, but you need to know how to deliver a baby who or a fetus who is having shoulder dystocia. You need to know how to deliver the position. So I'll show you a picture. I ever met a question on shoulder dystocia, and they showed 4 pictures, and you were to choose which of them indicate McRobert's maneuver. Okay. So McRobert's maneuver is, how you deliver, the how you position the baby, sorry, the mother during this period in order to kind of um widen up the space so that the baby can come out. So shoulder dystocia is an obstetric emergency in which the head emerges, but the anterior shoulder remains wedged behind the pelvis. Okay, so the shoulder remains behind the pelvic, the maternal symphysis PB, sorry. So the head comes out, but the shoulder remains inside, and then it becomes difficult for you to then deliver what you call the baby. So obstetric emergency, it is obstetric emergency. So here too, you might have to consider prioritizing them first if the woman is experiencing shoulder dystocia. So what happens is that the head comes out, then you have the shoulder get wedged behind them, the symphysis pubis. The fetal head retracts back towards the maternal perineum after the birth of the head, right? So we call that tatal sign. Condition is mostly associated with macrosomia, right? And so when the baby is very big, so that is why we learned about gestational diabetes and then it associated, effect on the fetus, that it could lead to what you call macrosomia, a very big baby. And so that is why also if the baby is too big, they might want to go in and do cesarean section to take off the baby, right? And so One thing that can cause shoulder dystocia is when the baby is too big. Okay. Shoulder dystocia is unpredictable. It may be related to suboptimal pelvic shape, obesity, short stature, rather than the size of the fetus. So, yes, the size of the fetus is a factor. It's not only the size of the fetus. The mother's condition, okay, also can cause the fetus to also or can also cause shoulder dystocia to happen. So if you have a woman, right? If you have a woman who if you have a woman with a short stature, so when we're in school, we learned about the various pelvics. I mean, our midwives are very good at it. We have, I mean, the suboptimal pelvic bone or pelvic shape for delivery, right? Gynaecoid pelvics. We have platypuloid pelvics and all that. Okay. As we know, the most appropriate one is on gynaecoid, right? And so if you have a very short stature, for people who are very short, excuse me to say that, they tend to have suboptimal pelvic bone. Okay, and so during delivery, they might experience what we call shoulder dystocia, right? So that is why people who are very short when they get pregnant and all that, I mean, because of this kind of complications, they might not allow them to undergo normal spontaneous vaginal delivery in order to prevent. So it's sometimes not much of the shape of the fetus, but the mother also counts when it comes to the shape of the mother or the stature of the mother, as well as that of the pelvic bone of the mother. Okay, it has to be of the normal female pelvic that supports what we call normal spontaneous vaginal delivery, which is gynecoid, right? Then, when someone is experiencing shoulder dystocia, what the NCLEX wants you to know, of course, the NCLEX want to know whether you know signs of shoulder dystocia, which I've talked about. The mother is delivering, fetal head has come out. Then you have the shoulder get wedged behind the symphysis pubis. Now they want to then know that what are the things that you can do during this stage. So you perform what we call McRoberts maneuver. So this is where you flex a sharp flexing of the maternal thighs towards the abdomen to widen up the space between the pubic bone and that of the sacrum so that the shoulder can now pass through. And then you apply what we call suprapubic pressure. That is a downward pressure applied to the maternal pubic bone to dislodge what we call the fetal shoulder. So now let me show you how shoulder dystocia looks like. Everybody here, you need to know shoulder dystocia so that you can identify shoulder dystocia. Okay, so let me see if I can get you a picture. Okay, so so this is mhm. I want so let me use this. Let me use this. I hope you can see. So this is McCovert's maneuver, which is an intervention that is used in delivering that picture I wanted. Okay, so okay, this one is rather giving us the sequence, right? So here you see that the head has come out and the shoulder over here. So here is telling us the head coming out first. Then over here, the shoulder gets wedged behind what you call the symphysis pubis here. And so delivery of the posterior shoulder, that's not what I actually want. Let me see. I wanted this picture. I guess you can see this image. Let me, sorry. I guess you can see this image, right? So that is what I want to use. This is how shoulder dystocia, McRobert maneuver is performed. So you need to know how it is performed. They can present a picture to you and then ask you which of them indicates shoulder dystocia. Sorry, indicate McRobert maneuver used in what you call shoulder dystocia. So first flex the thigh. Okay, you flex the thigh towards the abdomen. Then you press, okay, you apply pressure. Okay, you apply pressure over there, and that will help dislodge the shoulder that has got wedged. So we all need to know this kind of position and then what it is being used for. That it is used in managing what we call shoulder dystocia. Okay. So we said that shoulder dystocia, you have the mother flexing the thigh right towards the abdomen, then you apply pressure on the or you apply suprapubic pressure. That will help to dislodge what we call the fetal shoulder. So please, that is on shoulder dystocia. It is obstetric emergency. You will come across it. You will come across it in your readings and in your Q banks. And then what you do for the woman and that of the baby in order to get the baby delivered. Any question, any addition on shoulder dystocia?
Hello, sir.
Yes.
Mister, can you come again with the intervention, like how it's being done? Please, thank you.
How it is done. You need a practical, you need a woman. So it's here. So first it says that it is in two parts. Okay. So you flex the maternal thighs towards the abdomen. That is it. And what it does is that it helps to widen up the pubic bone and that of the sacrum. But the main thing is that you have to flex the thighs towards the abdomen. Then when you are done, you apply suprapubic pressure. Okay. You apply suprapubic pressure. And that is what I showed you. I don't know whether you were monitoring from the screen. So you could see the image I showed you. You realize that the thighs has been flexed towards the abdomen, and then there was a pressure being applied. So one hand kind of lifts the thigh towards, so you can use your left hand to lift the thigh, right? So of course you are lifting both thighs, so not only one. So you lift the thighs towards what we call the abdomen. You then pressed on the suprapubic area. You apply pressure there. Okay. I don't know whether I have to show the image again. Let me see. So
Yes,
this is
please.
the image. So you can watch from here. This is what I showed. So the thighs, this is the legs. Okay. Of course, I said the two legs, you flex the two. So you flex the thigh towards the abdomen. Then you apply the pressure on the suprapubic area here. So this is it. So another thing, another image is this one. Let me clean this so we can see it well. So let me try to see if I can get this widened up. When I clicked, let me see. All right, so this is it. For those who are monitoring on the screen, this is it. So we flex the thigh towards what you call the abdomen. Then we apply pressure. So here is where the pressure is being applied. Okay. So over here, so this is the area where the pressure has to be applied. Then the baby. So of course, if you are doing this, you definitely need assistance. You might not be the only person to do this. So someone assisting with the macrobes, then someone also delivering. So over here, you notice that the pressure, when the pressure is exerted, it will help get the shoulder that has got wedged here to be dislodged so that it can deliver the baby appropriately. So this is shoulder dystocia, and what we use. Note this, it's Macrobert maneuver. Okay, and what it is being used for. For. So that when you are reading your question and you come across shoulder dystocia and they ask which of the following intervention will need to be performed, and you have Macrobert maneuver, and you have whatever is there. Sometimes they might not say Macrobert maneuver, they will describe it for you. So you have to know the description. So we say the description is what? Flex the thigh towards the abdomen, and then you apply pressure, right? Suprapubic pressure, or you apply pressure around the suprapubic area. That is with what Macrobert maneuver is.
Thank you, sir. Appreciate.
All right.
Sir,
Let's.
please, which leg are we to flex? Is it the right or the left?
Yeah,
Because
flexing
NCLEX.
both of them. So what I showed you, so look at this. Look at this one woman. If you are looking on the screen, haven't you seen that both had been flexed? Just
Okay,
that the first one I showed you, they only show like only one part, okay, because it's an image. But this one is rather giving you a clear view. Okay.
okay,
So this one is both thighs you are going to flex, not only one. So you flex both thighs towards the abdomen.
okay. Thank you, sir.
All right, thank you. Yes. Okay. So let's do ruptured uterus. When the uterus ruptures, what do you do? Another obstetric emergency. So, of course, uterus can rupture from pressure, especially during RTs. And so when someone gets RT and the abdomen gets affected, the person is pregnant, the pressure from the RT could cause the uterus to rupture. Another thing too that could cause the uterus to rupture is when, let's say, the person had cesarean section done, and in less than 2 hours, in less than 2 years, the person had got pregnant and the person goes into normal spontaneous vaginal delivery, the pressure from the labor contraction and all that would cause the uterus to rupture. And so that is why if someone is pregnant and the person had cesarean section being done, and then that is less than 2 years, the healthcare provider would never allow such a woman to undergo SVT. They would definitely do cesarean section to prevent uterus from rupturing. And so if the person has a previous history of cesarean section, over the extension of the uterus when there is multifetal gestation, or yes, multifetal gestation after cesarean section, or if there is what we call abdominal trauma, just like I said, these are some of the things that could cause someone to experience the membrane to be ruptured. Okay, so when you have abdominal trauma, having a previous history of cesarean section, and in less than 2 years, you've got pregnant again, and now you are in labor and you want to undergo normal spontaneous vaginal delivery, that pressure could cause the uterus to rupture. And so, a rupturing of the uterus is where you have a separation of the uterine tissue as a result of a tear in the wall of the uterus from the stress of what they call labor. I mean, there are types which is not quite of interest when it comes to interest. We could have complete. And so complete, it just the name goes, just like when you have a complete fracture, the bone breaks into two. And so the same thing, the uterus could rupture completely. and then you have the content of the uterus communicating, okay, or the uterus, the content of the uterus found inside the peritoneal cavity. So we say that communicating with the peritoneal cavity, right? It's a direct communication between the uterus and that of the peritoneal cavity. And so everything that is in the uterus had been poured, if I want to go that way for you to understand it, into the peritoneal cavity. So that is a complete rupture, just like when you have a complete fracture and the bone breaks completely, right? And then you can also have incomplete. And so incomplete, you have the peritoneal covering still around what we call the uterus. You don't have the content of the uterus communicating directly with the peritoneal cavity. And so and that is with the difference between the two. Like I said, it's of not, much interest here, but just for us to know that you can have a complete um rupture of the uterus and then incomplete. The assessment, one, there's going to be abdominal pain, severe one, and as well as tenderness. So chest pain is also another thing the woman can experience. Contraction may stop or fail to progress because what is going to contract had ruptured. So there's nothing else again to cause the contractions. So contraction may stop or fail to progress. There is rigid abdomen. The rigid abdomen is because of the content that is now in the abdomen, which is now tensed, right? Which is now tense. So there's tenderness. And so there's going to be rigid abdomen. Absence of fetal heart rate, okay, signs of maternal shock because the woman is going to bleed profusely, and then fetus palpable outside the uterus, especially in complete what we call rupture, because the uterus had ruptured, the fetus is no more in the uterus. So if you go assess go palpate around where you expect to see the uterus, you might not see. You might rather palpate the fetus inside what you call the peritoneum or the abdomen rather, right? So fetus palpated outside the uterus. And when it comes to your management, here too, hemorrhaging is a concern. Hemorrhage is a concern. So first has to monitor for signs of shock. Definitely the woman is going to go into shock. So monitor and treat signs of shock, and then in treat show signs, you look at heart rate, you look at blood pressure, you look at respiratory rates, and then you can do your physical assessment, skin Fairgall and all that, okay, pallor and all that. Then you administer oxygen, IV fluids, and then blood products. You also have to prepare the client for cesarean delivery and then possible hysterectomy to be done if necessary. You provide emotional support for the partner and all that. And so when it comes to rupturing of the uterus, it's a no-go area. And so when you are preparing, you need to be ready to monitor what happens to the fetus. Definitely the fetus is not going to survive. Watch a video on YouTube how the procedure is conducted. Okay, so you were that is the McRoberts maneuver. Eh? All right. Thank you. Is the maneuver done simultaneously? Okay, so you were asking if it's done simultaneously. I don't know. Of course, the moment you notice that the person is experiencing shoulder dystocia. Yes, it's so it's like it's in stages. So the first one is to do the flexing of okay, so you are okay. All right. You're okay. But I just wanted to say that of course it's done simultaneously once you are doing your delivery. Okay. Now someone was asking what happens to the fetus if there is rupture of the uterus or when the uterus ruptures. The fetus is more at risk of, there's, about 90% chance that the fetus is going to die, of course. So there's high chance that the fetus is not going to survive. Because we even said that there's likelihood of what you call the fetus, when you do your assessments, there's no going to be any form of fetal heart rate and all that. So definitely the fetus is not likely going to survive this kind of complication. Okay. So that for those the one who wanted to ask about that. Any other question on a ruptured uterus? So when someone is pregnant and the person get RT, very bad one of the things you want to monitor for is ruptured uterus, right? Then our last thing we touch on before we do our question is on when someone experiences uterine inversion. So here you have the uterus completely or partially turned inside out. So after the fetus is delivered, after the placenta is delivered, the uterus has to return back to its normal position and shape. Remember the last time when we were talking about stages of labor, I spoke about the third stage, which has to do with the delivery of the placenta, and why after the placenta is delivered, you have to go ahead to assess to see that all the parts are intact. There is no left over, or there is no retained product. Because when there's retained product, or the placenta is retained, or a product or a part of the placenta is retained after delivery, it could cause what we call uterine inversion, and then the uterus could turn what you call inside out. So this can occur during delivery or after the delivery of the placenta. Mostly, risk factors are when you have fundal implantation of the placenta, when you manual extraction of the placenta, and then when you have shortening umbilical cord or uterine atony, when the uterus is not contracting adequately after delivery, it could cause this to happen. And then when you have some form of abnormal tissues or abnormal growth, that is leiomyomas, could also cause uterine inversion. So abnormally adherent placenta tissues would lead to uterine inversion. Assessment for uterine inversion. One, there is a depression in the fundal area of the uterus. The interior of the uterus may be seen through the cervix. So you do your assessment and then you can visibly see the inside of the uterus through the cervix or protruding through the vagina. The client has severe pain. Okay. The client experienced severe pain because, of course, the uterus is not contracting adequately. And so the person will go into pain. Hemorrhage is evident because the uterus has to contract. Remember, I told you that in the stage 3, the purpose of contraction is to deliver the uterus. After the uterus is delivered, sorry, I said the uterus, deliver the placenta in stage 3. After the placenta is delivered, stage 4, contraction has to happen to press on the blood vessels to prevent bleeding. And so if the uterus is not contracting adequately, and that kind of pressure to be exerted on the vessels to cause it to constrict, to prevent bleeding, is not happening, then eventually the woman is going to bleed. So signs of shock will also be there. You have to monitor. And so with uterine inversion, you have to monitor for hemorrhage and shock, treat shock, IV fluids, blood product, oxygenation. Then you prepare the client for return of the uterus to the correct position via the vagina. If that is unsuccessful, the client might need a laparotomy to be done to help correct what we call the position, or to help correct the uterus back to its normal position. And so that is just briefly on uterine inversion that can happen after labor or after delivery, where you have the uterus not returning back to its normal position, rather turning inside out, which you can even visibly see it through what you call the cervix. And then it's accompanied complication. Risk factors, we've said leiomyomas, abnormal tissue, abnormal growths. You could have uterine atony. You could have, when you manually extract what you call the placenta, it could cause it to happen and all that. So that is on uterine inversion. Any input, any addition on uterine inversion before we talk about our questions for the day? Any addition?
Prof, I think mine is a little contribution towards
Okay. All right.
ruptured uterus.
Okay.
Yeah, one of the risk factors that I didn't hear you mention is hydramnios.
I think it was
It's
there.
also, it was the, oh, okay. All right.
What was it? But you can
I
go ahead. Go ahead with it.
Yeah, so it's also
It's
one of
here.
the risk factors that can cause the rupture. So I didn't hear you mention it, so I just wanted to add it.
Yes.
Yeah, thank
Yes.
you.
So it's over
Mm.
here.
Oh, okay.
For those who
Mm.
are monitoring from the screen.
Oh, okay. Thank you.
Yes. Okay. So thank you for also bringing that up. Thank you for adding up. And so you have excessive buildup of fluid. So it's also pressure. It's just like when you have the um multiple features and then there's overdistension of the uterus. So the overdistension of the uterus could be as a result of multiple features or excessive amniotic fluid, right? So that is when you have polyhydramnios or hydramnios, if you want to put it in simple terms. Thank you for the addition. Yes, any other input, any other clarification? Is there anyone who wants to add up? Okay, so let's go through these questions briefly. The nurse is performing an assessment on a client who has just been told that a pregnancy test is positive. Which assessment findings indicate that the client is at risk for preterm labor? One, the client is at 37 weeks. Sorry, the client is a 35-year-old primary gravida. The client has a history of cardiac disease. Three, the client's hemoglobin level is 13.5. Then the client is a 20-year-old primary gravida of average weight and height. This is very simple, right? So let's answer very quickly.
Samingo,
Yes, madam.
hi, I want to try.
Okay, kindly go ahead.
I wasn't paying attention though, but since I've seen one opposite the other, I will choose the other one, which will be the 35-year-old premium gravida.
Okay. It is
Yeah,
opposite to which one?
to the 20-year-old premium gravida. So
In fact, okay.
using the age as a risk factor, I'll
Okay.
go for that one.
Okay. In fact, we are not paying attention. Let's
I
start
heard
from
you
here.
said 18 to 40. I wasn't paying attention. Today is my son's birthday.
Okay, happy birthday to your son.
Yeah, so
So,
I'm doing some kind of rounds.
yes, you
So
are
I'm
doing
here.
some rounds.
I'm here,
So,
but I'll choose that one.
okay. So
All right.
she says she's going for, all right, thank you. She's going for A. That's the first one. Okay. She told us why she's going for the A. But then let's look at what others also have to say. Yes, so those who want to also answer, yes.
Prof, I also go for the the history of cardiac disease, because the 35 doesn't fall within the 40 years and above, and the 20 years is within the normal age, and then the hemoglobin too is normal. So I'll go for the 2. That is the
Go
cardiac,
for it.
because the cardiac issues can also cause prematurity.
Okay. Okay.
Yeah.
All right. Thank you. So she's also come up with her answer and rationale. She says she's going for 2. She's elaborated on why she's going for 2. Thank you. Yes. So now it's now between 1 and 2, eh? Okay. So hey, so the only 2 people responding to the question, even in the comment section, I've had only 2 people reacting. Where are the rest? Or you don't want to answer, you're keeping your answer. Okay. All right. Okay. Let's continue. So clearly using the what we spoke about on preterm risk factors for preterm labor. The 1 and 4 are out of, the age I gave you. And so we said the optimal age for, labor or pregnancy is between 18 and 40. So after 40, your risk increases. And then when you are also less than 18, your risk increases. But 35 is part of the optimal, 20 is optimal. And then just as we know that 3 is fine, hemoglobin is fine. So, the outliner is the second one. So the correct answer is 2. So thank you for your inputs. All right. Let's look at this. A nurse is caring for a client at 30 weeks gestation who is admitted for preterm labor. Which of the following interventions should the nurse anticipate? Select all that apply. 1. Administering IM beta-metazone. 2. Administering penicillin via IV piggyback. 3. Assisting with artificial rupture of membranes. 4. Initiating IV max sulfate. And then 5. Obtaining beta-hactone once per shift. Yes. So who is going to help us answer this?
I will choose 1 and 4.
1 and 4.
Yes,
Being
sir.
sleep game. All right. Thank you. Yes, who again? or you are putting your answer in the chat box. Let me see. 135. 14. Tell us more. Want to listen more? 145. Tell us more. Come up to defend your answer. I want to hear someone defending his or her answer. Uh-huh. One will help with the lungs. And what of the four? Okay, sorry, this is mommy who is answering. Okay, mommy, so did you choose only one? Or you choose
Yeah, I chose
uh-huh.
I chose 1, 3, and 4. But right now I want to choose 1 and then 3 because the 4, the magnesium sulfate is to
Uh-huh.
prevent the labor.
Uh-huh.
So this one, the labor has already started.
Uh-huh.
So you give the betamethasone to enhance the lungs, and
Okay.
then you rupture the membrane to let
Onto
the
the
liver progress.
uh-huh. Okay.
To let the liver progress, yeah. So I would
Yeah.
choose the number 1 and then the number 3, 1 and 3.
Okay.
Okay. For me, sir,
Amigo.
I choose 1 and 4.
Uh-huh.
And I choose 1 because of the fetal lungs maturity.
Mm-hmm.
And the 4 because magnesium sulfate is used in preterm labor mainly for neuroprotection.
Mm-hmm. Mm-hmm. Okay. Mm-hmm. Okay.
Amigo.
Yes, madam.
I'll also choose 1 and 4.
1 and
Uh,
4. Okay.
yeah, because 1, the betamethasone will be given to help mature the lungs of the child, the fetus, sorry. And then administering penicillin via piggy bank, I think normally it's when there's a premature rupture of membrane that puts the child at risk of that puts the mother at risk of infection. That is when sometimes we give antibiotics. And then for Maxolf is a tocolytic that will help to slow down contractions. And then 5, obtaining the beta heart tones. For me, for that one is once per shift. That made me not choose that one. That a whole shift you check only once. Thank you.
Okay. So your final answer is 1, 4, right?
Yes, that.
We didn't comment on the third one.
Um,
What do you think?
I think that if you are trying to if you are giving tocolytics to slow down labor, you wouldn't artificially rupture the membrane.
Membranes, okay. Okay. All right. So, all right. Okay. So others have given us 1, 4. Others have added 1, 3, 4. Others even added the fifth one. Okay. As for the one there, everybody understands that you need to give your steroids. And then the fourth one, you need to give your tocolytics, which is the max of it. Now, the second one, the antibiotics, is to cover up for infection. Okay, so it's for infection purposes. Okay, we said that if the person is is in labor or the person is in preterm labor, what you want to prevent is infection. When, especially as expected, that definitely if the labor continues, the membranes will rupture, and when membranes ruptures, infection becomes a concern. So the infection, the antibiotics is more of to cover up, okay, to prevent infection that could also spread to the fetus. So that is why they included all the antibiotics which the penicillin will be given. Okay. But we don't artificially rupture if the membrane hasn't ruptured. Okay, so don't go for artificially rupture the membranes in preterm. Allow it to rupture at a spec because we want to even hurt the labor. That is why we are giving our tocolytics. So if you are hurting the labor, why would you want to give or rupture the membranes? Okay, so understand that even though we say that labor had set in, it is preterm and you can halt it. That is why the medications are there. And that is why we are also giving they are also giving the steroids, okay, so that we can halt the labor and then give the steroids so that the steroids will help with the lung maturity and probably you can sustain the pregnancy for some time and then allow the labor to continue. So we don't artificially rupture the membrane if it hasn't happened by itself, okay, during during preterm. And just like she said, the monitoring once per shift is not enough. Someone who is experiencing preterm labor and you say that you do assessment once per, that's why I said, when you are reading your question, pay attention to details. You see that they say obtain fetal heart tone, which is normal, which you have to do. But look at the consistency at which they are saying you should do. They say you should do it once per shift. Is it normal? It is not normal. Even though it is good you do your fetal heart rate monitoring, but how often should it be? Or should it be just once per shift, which is not enough? I hope you are getting me. So
Okay,
always
but I mean,
read. Yes, madam.
please, let me ask this first. Please, I'm sorry I cut in. If it was 37-week gestation and labor has set in and assisting with artificial rupture of membranes was part of the option, that one would have assisted to do it, or in
You
NCLEX, we don't
said
do
you said the
artificial
labor
rupture.
is what gestation? 37.
If it was 37 weeks, like a
37
normal,
is term. Term gestation.
yeah,
So
so
for
if it
that
was
one,
10, we can assist. Okay, okay.
yes. So for that one you can do. Okay. 37 is 10. You can do. So you can do. Any other question? Let's look at this. A nurse is participating in an obstetrical emergency simulation in which the healthcare provider announces shoulder dystocia. Which of the following interventions should the assisting nurse implement? Select all that apply. 1. Assist maternal pushing efforts by applying fundal pressure during each contraction. 2. Document the time the fetal head was born. 3. Flex the client's legs back against the abdomen and apply downward pressure above the symphysis pubis. 4. Prepare for a forceps assisted birth. 5. Request additional assistance from other nurses immediately. So, all right, people are going in for their answers. They are going in for 2, 3, 5. Okay. Yes. All right. So let's see. Then, oh, sorry. I think I already showed you 2, 3, 5. So we are correct. So 2, 3, 5. We need to document. We need to call in for support. And then we need to perform our McRobert maneuver. So you realize that the option 3 was describing McRobert maneuver, right? So flex, the client flex. So if you don't know that that is McRobert maneuver, you might not select it. You might go in for probably pushing efforts by applying under pressure. But from today, you know that when shoulder dystocia happens, it's McRobert's maneuver that is done. Thighs flex towards the abdomen, pressures apply around the suprapubic area. That is it. So we don't use what we call forceps, okay, for delivery. You could cause injuries and all that, okay. So I hope we all got it. If you are, is there anyone who, when do we use option 4? What was the option 4? Use read here. Okay, where is it? In fact, the use of forceps or vacuum to facilitate birth are contraindicated. In actual sense, the most appropriate thing to do is what we spoke about. You want to prevent complications with it. It comes with its own complication when you are using the forceps. I don't know whether it is still done. Our midwives here, I don't know whether you guys still do it. Going to use forceps to hold because of tear and other things. Yes, you could do it, but it's not the right thing to do. And so don't go choose it. Okay. And it also increases the risk of neurological complications and all that, the newborn. So I don't know whether they still performs that. I don't know, but I mean, forceps assisted birth is not an ideal procedure when it comes to childbirth because of complications associated with it.
Actually, I haven't practiced my midwifery for a very long time. I did it in the 80s, and I haven't practiced it for a long time. So
Okay.
I can't really tell.
Yes, yes. So because of
Yeah.
it's more of an outmoded kind of
Yeah.
procedure to assist with delivery. So it's not largely done anymore. Let's look at this. Following the presbyterian birth of a termed newborn, what is the best action by the nurse whilst awaiting expulsion of the placenta and arrival of the healthcare provider? 1, clean the perineal area. 2, gently pull on the cord. 3, keep the infant warm. 4, massage the fundus. Question looks simple, but it's kind of tricky. Let's see what we have to do here. Okay. I say massage the fundus. Why should we massage the fundus? That's my question. Don't mind me, eh? Why are we I'm not saying change your answer, so okay. So why do we think we should massage the fundus? Why should we keep the baby says what? Keep the infant warm. Why do we keep the infant warm at this point? And there's how I'm going for 2. 2 says that pull on the cord. Why should we pull on the cord? That is another question that needs to be answered.
Boss Amigo,
Yes, madam.
the reason why I chose 4, I don't know whether it's correct or not, but there's 2 reasons why I chose 4. Because massaging the fundus, I know that in precipitous labor, there's a risk for bleeding. So massaging the fundus would, I think it will do 2 things. Will help with the expulsion of the placenta, and 2, it will help with contraction of the uterus to seal all the, to prevent bleeding.
You. Okay. But there is no, statement made in the question, the stem of the question, for you to think that the uterus is not contracting adequately. They haven't made a comment on whether the uterus is firm, the uterus is bulgy, and that. That is when you might think of doing massage. And so they just said you are waiting to deliver the placenta. So it means that you just delivered the baby. What is the next action? Whilst I'm waiting for the healthcare provider to arrive.
Boss Amingo.
They didn't make mention of the state of the uterus at this point. So yes, someone also wants to comment.
Yeah, I was
Okay, so
also.
I went for
Oh,
3.
sorry.
I went for 3 because after birth, the newborn loses heat very quick. So you need to keep them warm to prevent hypothermia. That's why I went for keeping the infants warm.
Okay. So forms of heat conduction. Right. So
Yeah.
I forgot to say this. But heat conduction in newborn. Right. Let's look at. So we are looking at a question altogether. And someone wanted to go for the second one. I wanted to ask the person why pull on the cord. Allow the cord to come out normally. Don't go pull on anything. Okay. Don't go. You remember what we spoke about uterine inversion. When you manually extract what you call the placenta, it could cause uterine inversion. So Don't go pull on the cord. Allow it to come as expected. And so just like I was saying, there was no mention of the state of the uterus. So for you to think that the uterus wasn't contracting adequately, and so you might think of massaging, right? So it is when the uterus is not contracting. So pendal massage is performed after expulsion of the placenta to increase uterine tone and then decrease bleeding. And so you, just like someone said, you need to make sure you are keeping the baby warm, okay? To prevent heat loss and all that. What was the first point? The first point, clean the perineal area. You have not even finished your delivery. So then the second one, I said we don't pull, okay? And so you just to prevent tearing and all that, you just allow it to come as expected. So the nurse should not pull on the cord. That is what we have to take note of. So that's why I said the question looks very simple, very easy. Like you might think too much and get it wrong. So let's do our last one. Our time is up. Today I started early. Okay. So we'll end just like we don't want to take people's time. Okay. Maybe from here, someone wants to do
Hello,
something.
boss.
Yes, hello.
Please, sorry, I missed it. So what's the final answer?
The final answer is to keep the baby warm.
Okay, right. Thank you.
All right. Let's look at this last question. A client who is a gravida for part 3 at 38 weeks gestation arrives in the emergency department with strong contractions that began 1 hour ago. The client is diaphoretic, grunting, and yelling loudly that she wants an epidural because she feels the need to push. What priority action should the nurse take? 1. Apply glove and assess perineal area. 2. Initiate large bore IV access. 3. Notify the anesthesia provider for client request for epidural. And then 4. Obtain fetal heart tone via Doppler. Yeah. So, by the way, what do we think is happening based on the assessment from the question? What do we think is happening based on assessment from the question?
Yeah, it can be a precipitate labor.
It can be a precipitous labor. So, Sefa, you are here. So you look at if you read, you were asking about how you know that so you look at what they are saying. It says that the client reported and said that the contraction happened 1 hour ago. And they are saying that the client is diaphoretic, is grunting, is yelling loudly that she wants epidural because she feels that there's a need for her to push. So these are all indication that this client is going into labor just like that, or is just at the edge of, delivering. And this is 1 hour ago, she started having her contractions. Okay. All right. So now let's look at what people are going in for. Interesting. So now, those going for 4 and 1, tell us why you're going for 4. And tell us why you want to go for 1.
Yeah, I chose 1 because you know the client is the client wants to push, and when you have that urge to push, it means you are getting to the ending of the second stage, that you know the baby is coming. That is why the nurse should assess the perineum to make sure that if the head is in the vagina, or if we still have to give the client time to go through the labor.
Okay.
And for me, I choose 4 because of the question is asking about priority action. And the patient has been on labor, on contraction for like 1 hour. So I need to know the fetal heart tone.
Okay. All right. Okay. Oh. So now it's between knowing fetal heart rate or the fetal heart rate and then assessing applying gloves and then assessing perineal area. Okay. Okay. So let's look at what it is. So yes, the correct answer is 1. Okay. This is presbyterous labor. And we're saying that presbyterous labor, the main thing is to deliver the baby. Okay, of course, assessing the fetal heart rate is important. But at this point, if the client tells you that, you know, for if you go to the labor ward, if they are about to enter into stage 2, that is delivery of the baby, they tell you that they feel like emptying the bowl or something had come, and I mean they can feel something around their perineal area. That tells you that probably the presenting part is just there, it's coming. So the main thing at this point is to assess to see that is it the presenting part that is there. So you go ahead to deliver the baby. Okay. So yes, assessing the fetal heart tone is important, but then the main thing here is to assess to see whether of course. So now you're looking at priority. We are looking at which of them can save the baby and can save the mother. Between checking to see if the presenting part is actually there and then progressing with the delivery, and then checking the fetal. So if you check the fetal heart tone oneness. So remember it's presbyterous, and we said that presbyterous, the main thing is to go ahead and deliver the baby. Okay. So if you read the rationale, it will tell you that the nurse should rapidly assess whether birth is imminent by applying gloves and observing the perineum for bulging or clearing of the presenting parts so that you can deliver the baby. And so that is that. So presbyterous labor, it's interesting when you read the questions, look at the onset of labor and when the client is showing signs of stage 2, that is the woman going into labor. And that is that. Any question? So we want to drop it here. Like I said, tomorrow I'll try to see if I can finish this so that we tackle a different thing. All the recordings on this very class is available. If you joined us recently and then you missed the beginning of it, you can request for it and then it will be shared on the page again. You can have access to it. Yes. So let's end it here.